If I can ask everyone to go on to mute. And so welcome to the March South Warwickshire NHS Foundation Trust Board. Absolutely delighted to have members of the public, as well as to be recording this board meeting for members of the public who aren't able to join us now. But before we get the meeting going, I just want to say thanks to a few people. As members of the public are aware, this has been the most extraordinary year in the history of the NHS, and the work of our frontline teams has been the most demanding, and all of them will have ever known. And the emotional and physical exhaustion that they will have felt will have been unprecedented. And as I've previously said, our thanks go to them and to their families for the support they've given. But over the last two nights, Channel 4 have been running a series of interviews and observations in Warwick Hospital of our staff, talking to a number of them, and they came across as absolute heroes and represented their colleagues in an extraordinary way. All NHS staff are extraordinary, but those at SWFT, in my view, are exceptional. So I particularly want to thank Carly, Bash, Marcia, Sarah and Dina for their ambassadorial role and the way they came across. My wife was in tears last night listening to Carly, and so thank you very much for the work you do day in, day out, and for the support of your families. I also want to just thank Zoe, who's been the administrator for the board meetings for quite a while now. Zoe's decided to do some other things. So Zoe, thank you to you. So as I said, welcome to everyone. Could I ask everyone to turn the videos off, apart from Glenn and I? Have we any new declarations of interest? Please raise an electronic hand. Thank you. The minutes of the meeting held on the 3rd of February. Was everyone happy with the accuracy of those minutes? Please raise an electronic hand if there was an issue. Bruce?
Thank you, Russell. I just suggest that on page 8, that is item 21012, actually top of page 9 of the minutes, the second line of the last paragraph, it says highlighted the merge, and I suggest we delete merge and put in agreement of the joint terms of reference, which is what we actually did.
Thank you, Bruce. That's helpful. Any other amendments to the minutes? Okay, so then moving on to action points arising, which are on page 22 of the pack. The first was Kim to submit a report on the shared services of finance and procurement to the next board meeting. That's on the confidential agenda. Thank you for that, Kim. And then Anne Coyle and Rosemary to discuss outside the meeting those low probability events that could have an enormous impact on the trust. That's been done. And I do think, as part of our thinking going forward, we need to really look at the 1% or 0.5% risks, which can have a disproportionate impact. And this morning, for members of the public, we were talking about the bed review, which we're currently undertaking, and our ICU capacity going forwards. On the integrated dashboard report, Helen would bring feedback on the perfect week. How did that go, Helen?
Thank you, Russell. Yes, the perfect week went really well, and they're going to do a perfect weekend. Because unfortunately, they stopped at 5 days, so they're going to do a perfect weekend. We're going to pull all of that together, because it was really important to look at the 7 days. And I think we were just looking forward to workshop and board agenda for next month, and I noticed on there is the winter look back for April, and I think it's well worth probably pulling all of that together so that we can start to think about what our assumptions are for the next winter, because I don't think that will be the first time we talk about it, because really understanding what we are going to go through next year or this winter as we say, is going to be some challenge for us. So we need to put some thought into that. So I think the best practice I'll bring back, but I think it's about how do we then move forward for the rest of the year.
Okay, agreed. Thank you for that, Helen. And then Kim would bring an update back on the elective incentive scheme, annual leave accrual scheme, and non-NHS income. Kim, I guess that's not ready yet, is it?
So the elective incentive scheme, we don't know where we are for next year on that, but for this year, there's no penalties and no gain for the trust or for the system. We're still yet to find out about anything else.
Thank you, Kim. And on the block payment, the prepayment of the block payment, just please brief us on where that is at the moment.
Yeah. So that's we've had confirmation that that ceases for this for which month we're March. Sorry. So yes. So we're now moving into the 12 months of a payment for 12 months of the calendar. Calendar for the financial year.
No, thank you, Kim. And that therefore will drop our cash balance by about 20 million.
About 25 million.
Okay, thank you, Kim. Then Glenn would contact UHCW to reinstate the Commentary and Warwickshire Pathway Network meeting. Glenn, I know you've emailed on that subject. Have we had a reply yet?
Yeah, so I had a meeting last evening with the network director. We discussed some of the operational issues that both the board and quality committee had raised. There is a strategic review going on nationally about pathology post-COVID, which may impact on the pathology network structure, but he has agreed that we'll reinstate the network meetings as soon as possible. That's likely to be April, because of what's going on at the moment.
Okay, thank you very much, Glenn. We will keep members of the public briefed on that. And then for the future, we've got Anne including some data regarding recruitment figures by gender profile. We'll come back to that in May. We've got Charles bringing back the medical revalidation report in November. We have Anne again inviting 2 members of the BAME network who have been allocated places on the National Res programme to a future board workshop that's scheduled for July. And then an update on recovery and restoration to be brought back when more progress has been made. Helen, do you just want to brief us on this? It sort of partly touches on what we were talking about a second ago.
Yes, of course, Russell. So this is mainly around where we are in terms of recovering the elective and the cancer position. And so we've been given some steer just last week, really, in terms of starting to pull back our position on some of the not the life changing and the life threatening position, but more around those surgeries that need to be done within a short period of time. So we've scaled that, or scoped that, the size of that demand across the system. And in between the workshop and board here, I've just chaired the first elective hub meeting. So how, as a system, we now begin to look at the size of the problem and how we are going to best use the system money to recover the position and make sure that we are treating patients in date order for those patients that have the most pressing conditions. So I'm hoping that within the next month we will see some further clarification, as Kim was sort of alluding to, in terms of what that elective recovery financial framework will look like, which will allow us to progress further and put some more firm plans in place. We're also expecting a phase 4 letter that my understanding today was we might not see that until sometime in Q1. And so we have started electives as of this week back again, and orthopaedics will be started next week. So we are starting to recover our position, but we just need to take that in mind that we need to do this now as a system moving forward. So as soon as I have more detail around any of those, but I think it will be worth us bringing back our current position next month against where we are against the old recovery trajectory, so you can see a bit of like with like until we get any further clarity on that.
That's great, Helen. But just again, in case members of the public aren't aware of the terminology, the notion, the idea behind the elective hub is to, given the level of waiting lists now, to allow the NHS to accelerate through that waiting list as quickly as possible. We're going to effectively pool resources with other providers to ensure that those who are on the waiting list are seen as quickly as possible, whichever location it might be.
Yes, yeah, absolutely.
Thank you, Helen. And then on the assurance report following Ockenden, we obviously talked about this last month, Fiona, but you'll come back again in August and give us a further update.
Yes, I will.
Thank you. Are there any action points that I've missed? Okie dokie. So we've got therefore some items for approval, the first of which is a compliance statement for same-sex accommodation standards. Fiona, over to you.
Yes, thanks, Chair. So this is your annual compliance statement that obviously we bring every year, just to remind board and the members of the public, there are national standards around mixing the different genders in sleeping accommodation. It doesn't apply to areas where the patient is not undressing, and doesn't apply always to high care areas such as ITU or coronary care, but everywhere else. Obviously, in those areas we maintain dignity as much as we need to, but it's not declared a breach. This year we've reported one unacceptable breach, and that's the terminology used in the national policy, is that they are deemed acceptable or unacceptable. Those that have got a keen eye would have noted that there was actually 2 being reported and 6 patients affected in the integrated dashboard. And that's because we did have one other breach in November, but following RCA, we've actually agreed with the CCG that that was acceptable because it was in the NIV bay that we've set up as a high care area. This one breach that we had this year is in CCU, where a patient no longer needed high care area, and the timescale within our policy is that they should be moved within 4 hours, and we didn't achieve that. We didn't find a bed necessary for them. That is deemed unacceptable because it's an operational, organisational issue rather than a clinical reason. So laid down in my paper what mixed sex means. I think the plans for the future, I just want to make sure that integrated dashboard reporting is in line with, it is only reported once the RCA is done, so we don't get that difference again, which I'm working with Greg's team on. And the other is I've asked Sue Pike and to support the trust in reviewing our mixed sex accommodation policy, which just needs to come more in line with inclusion and equality legislation, particularly around gender neutral. But other than that, happy to take questions.
Okay, very helpful, thank you. Question for me before I go to Glenn. For people who decide not to determine their gender, what's our policy with people who don't regard themselves as having a fluid agenda or don't want to determine their gender?
Yeah, and that's why we need to review our policy, because it's not clear in our current policy. There is clarity in our standards and policies at the moment around transgender, and we accommodate them in the appropriate accommodation to where their preference is, and we have to have that careful discussion with the individual, but also the bay that they're going into, because obviously that potentially affects those people as well. We try, if possible, to accommodate them in a side room if there is any dispute around that or any disagreement. But obviously with COVID, that has that will increasingly become more complicated and complex. So I think there is a need to review the policy, and that's why I was flagging it really.
Okay, thank you, Fiona. Glenn?
I was just going to observe, I mean, obviously maintaining the privacy and dignity of our patients is really important. Over the last year, there's been a significant increase in breaches across the NHS for understandable reasons, with the pressures of trying to maintain separate cohorts of COVID positive, negative patients, etc. So credit to the teams that we've been able to keep the numbers that low.
Yeah. And for board awareness, we did write an SOP about breaching mixed-sex if you know infection prevention required that, but we didn't actually need to do it.
Thank you, Fiona. Any questions or perspectives? If you're not happy to approve, please raise your electronic hand. Duly approved. Thank you, Fiona. So we'll move then on to the Board of Directors schedule of business for next year. Sarah?
Thank you. So this maps out all of the items that the board should expect to see over the next 12 months. It has already been shared with the executive team to make sure that we've got things aligned appropriately. So happy to take any questions and propose approval. Thank you.
Okay, thank you very much, Sarah, and thank you for your hard work in pulling that together. It's not a trivial thing pulling that matrix together. Any questions or perspectives? As members of the public can see, I'm fortunate in having a cup of tea delivered at certain points. If you are unhappy to approve the schedule of business, please raise your electronic hand. Okie dokie, so we move on then to the annual trust and foundation group objectives. Glenn.
Thank you, Chairman. So a quite small paper that defines the amount of work that goes into it. So each year we set out our objectives for the year we're about to just enter, and obviously we're in March now, and these obviously run from the 1st of April financial year. The start point actually of creating these is the roundtable events that we have with our governors. So we had round the screen event, is probably the best way to call it this year, rather than round the table, where we looked at some of the local priorities, but also I talked about some of the national priorities, and obviously there are going to be one or two national priorities this year that will dominate. And those are captured in this summary. This was we had a look at this in confidential board last month, made a couple of changes to them just for board members' notice. The fourth indicator, the fourth objective around recovery, which is one of those big ones I referred to, we've ensured that we add efficiency to it and an improvement approach to it. And then on the final one on that page, we talked about our digital strategy, and we put mobilising and embedding our electronic patient record system, which we spent some time talking about in workshop this morning also. So these objectives are a combination of things we're focusing on locally within the trust, but also some things that we're doing across the group where working together will make the response stronger. And those are generally the second half of that list. The one in the middle that talks about continuing to develop and implement support for staff health and wellbeing has now become a group-wide objective, and it's one of those two that I just referred to, which are probably the most important things. So the recovery of services for patients, but also the health and wellbeing of our staff, really vital. So if the board signs these off today, then you've already seen some communications on the back there about an overarching poster. We will then use these to frame the objectives for me individually, but also for executive directors and teams across the organisation. We'll also then look into detailed action plans that form our board assurance framework. That's what
Great, thank you very much, Glenn. And stating the obvious, as an outstanding foundation trust, we need to be very demanding of ourselves as a board, as a team, to be absolutely the exemplar that people expect in all areas of our organisation and operation. Any questions or perspectives to Glenn? We have discussed them as a board on a few occasions. Okay, everyone happy to approve? If you're not happy to approve, please raise your electronic hand. Okay, great. So we'll then move on to the Chief Executive's report. Glenn.
Great, thank you very much. So as you said at the start, Chairman, we were featured the last two evenings in Channel 4 News, and it was great to see our staff, their caring, compassionate nature, but also their personal stories about how they've managed over the last year. And you will have heard on that we have been seeing a reduction of hospital activity related to COVID. So this morning, the sit rep showing 24 patients in beds at SWFT. That's a significant reduction from the way it was a few weeks ago, where we peaked at around 140 patients. So it's great to see those numbers falling. Similarly, pressure on critical care has started to fall also. It doesn't mean that we shouldn't still be vigilant about COVID. There's still cases in the community. There's still quite a lot of COVID infection in the community. The numbers are still high. But one of the really positive things about what's happened over the last few weeks is we've started to see the impact of vaccination. So the national strategy around vaccinating those vulnerable individuals that are likely to result in hospital admissions has certainly been seen in our figures. And obviously, as we ease out of lockdown, you could see more cases in the community, but hopefully we'll continue to see a reduction in the impact of COVID and obviously the hospitalisation of those groups. So that's great. So I talk in here about the national vaccination programme. It's been updated since I wrote this report, so I won't go into the detail of it. The reason why it's been updated is the success of the programme. And if anyone saw Matt Hancock talking on Friday evening about that, you will have heard him mention the Coventry and Warwickshire system as the best performing. So real credit, I would say, to our primary care colleagues, particularly on this. They've done a lot of the heavy lifting. Vaccination of those age cohorts, and they're working through the clinically vulnerable groups now and the different age cohorts, and we should be really proud of the way the NHS has set about this, and I say locally we're standing out on that also. There is concern though, however, nationally in the percentages of individuals who have not been vaccinated in all age cohorts, that we could, if we're not careful, widen health inequalities. So we've been looking at that specifically locally. I met with the Director of Public Health for Warwickshire a few weeks ago and looked at how we could tackle some of the myths that are out there about vaccine, but also get to some of our hard to reach groups. Some of our black and minority ethnic groups particularly we've seen some low take up in some parts of the country. So we've started some comms work, did a video that's gone across the group. Went out this week, which is encouraging our staff to be those ambassadors, the trusted members of the community that friends and family will talk to rather than politicians, to get a sense of what the truth is. And we put some materials out for our staff also so that they can help to deal with some of those myths that are out there. So we'll keep pushing on that. Good story so far. Obviously, lots more work to do over the coming weeks and months. I then go into the National Integrated Care Systems legislation. I talked about this in more detail last month. This month, I'm just feeding back the fact that the consultation has finished, positive responses, and therefore a white paper has been produced, and will go through the legislation process with a view to it being implemented from April 22. It really enforces the fact that integrated care systems will be functioning across the NHS, but will be very much place focused. And this morning at workshop, we heard from the independent chair of our current STP, who's setting out our strategy locally to do that. I think the great thing about the agreement in the national policy for ICSs to be statutory bodies rather than just boards is that the ICS will have to be an independent body. So independent of all providers, and encouraging collaboration and integration. And as a West Midlands region, I met earlier today with the Midlands Star Board, and we're looking at how the capability of our current ICS models to be able to take on those new responsibilities. So there'll be some more work to be done on that over the coming months. I then refer to the Ockenden report. We spent some time last board meeting discussing that, but I just thought it was important to reference it here. Recovery and restoration, and I've introduced a new R word this month. So respite is my new R word, and obviously that ties back to what we all saw on our TVs last night. Our staff have worked incredibly hard over the last year, but there is a degree, there will be a degree of fatigue. Having said that, the sickness levels in our organisation are remarkably low. Our staff 2.8% was the latest SITREP figure I saw, which I think was the best in the region on the chart that I saw. So people are coming into work to make sure they don't let their colleagues and their patients down, which is great, but that can be draining. So we really need to make sure that we take care of our staff. But I also think we need to look now at what our capacity is post-COVID, and before we get a new set of national standards and targets to work on, so that we can decide how we can effectively recover to a different set of circumstances. And I think it would be wrong for us to say we're going to go back to the way we were before, because before we had some issues in productivity and inequalities that we need to ensure we don't continue to have in the future. Then some detail about our outpatient service, how they've responded to COVID, and they've probably gone through some of the most significant transformation over the last year, and it's transformation that we want to stick, particularly with the use of virtual appointments where we can, obviously face-to-face where we need to, and the flexibility that those teams have shown has been great. And just as an addition to that, actually only this week we've launched our patient portal, which we've rolled out in a number of specialties, which provides patients with access to their bookings and will give more functionality as we move forward. So some really good work by those teams. So I'm happy to take any questions.
Thank you very much, Glenn. And also this morning, members of the public won't have been able to visit the hospital, but we talked about some of the great infrastructure and building work that's been ongoing over the last couple of months within the fabric of the building. Any questions or perspectives to Glenn? We obviously had a long chat with Glenn this morning. I think it's also worth just emphasising, Glenn, our thanks to you for the national discussions you're involved in different places, both at regional level and national, which helps influence some of the discussions significantly, given your experience and wisdom, but also ensures the profile of SWFT and the foundation group is kept high. So thank you. Moving on then to the integrated performance dashboard. Anne?
Great, thank you, Chair. The performance illustration, the integrated performance dashboard, is really set within the context and occurred at the height of our COVID-19 response, when we had ITU capacity open and we were providing mutual aid within the West Midlands footprint, but also externally to that footprint. There are 3 points that I really, if I may, just draw out before handing over for detailed commentary. The first is the January Friends and Family test. How that improved in both the response rates and the percentage of patients who had a good experience of care received. Secondly, it's not surprising the impact on regulatory performance measures, but within that, I think it's very important to acknowledge the work of the Trust to maintain non-COVID-19 services during this period where it was safe and appropriate to do so. The third point, Glenn's mentioned our strong staff attendance figures, but I just wanted to also acknowledge, as set out in the Director of HR's report, the recruitment and our success in continuing to attract new staff members. I'm really looking forward to welcoming these new colleagues to the Trust in due course. And then just finally, just really thanking our teams for their fantastic teamwork and 100% commitment, particularly in the period of January. It's been a very humbling experience for me personally, and really I do support that addition of the new R word, sort of that respite following this unusual period. So hand over to at this point.
That's great, thank you, Anne. Colleagues, happy to move on to some of the detail. So thank you. So Fiona, first up, please.
Yeah, thank you, Chair. So just really, you'll have noted that in the quality and safety page there are more reds than normal, but just to give assurance to the board that most of those reds are associated with actually a pause of the standard through COVID, as we've talked about before. Those will be restarted as of normal and from April, with some of them already starting in terms of friends and family, as Anne alluded to. I think the only one that I would have some concern over, and I've asked for a thematic review to be done in Patient Safety Surveillance Committee, and then clinical governance is around pressure ulcers. We have had 10 avoidable grade 3 and 4 in year, which is unusual for us. So I just want to go back over those and see if there's anything that we have missed. In terms of the plan going forward, we're going to be reviewing the quality and safety KPIs for the new financial year, and we'll do that in month. And setting a revised target for some of those indicators through the Patient Safety Surveillance Committee and the local groups, such as falls, medication, incidents and pressure ulcers, and just resetting those so that we push that continual improvement. Other than that, I'm happy to take questions.
Thank you very much, Fiona. Questions and perspectives to Fiona? Sue?
Hi, Fiona. In restating the tracking, will that include the dementia tracking coming back in April? And linked to that, will that involve the services being back in place that were there in the acute? I'm just conscious of the impact on dementia of lockdown and the fact that many of those Admiral services, etc., were redeployed.
Yeah, they weren't fully redeployed, but yes, their service changed to reduce the footfall of some of those specialist teams into COVID areas particularly. We have actually now, only of this week, only got one COVID positive ward. So that service has now restarted and is going to those patients that, and the remote connection with the clinical teams and advice continues where it's not safe to actually visit the patient. So I'd say that service has already restarted.
Thank you.
Okay.
Thank you, Sue. Thank you, Fiona. Colleagues, happy to move on? Okie dokie. So I think we move over to you, Helen.
Thank you, Russell. And I think overall, January's performance reflects, I think, the peak, as we've said before, of of the COVID and the significant pressure that the whole organisation was under during January, and that is reflected through all of our performance metrics. I think there's a couple of things I just wanted to pull out, so I don't intend to go into large detail within the report because I do believe it's self-explanatory. I think if we look at our A&E performance, actually year to date, we're in quite a strong position. And whilst it's not where we would normally like to be as an organisation, year to date, we're at about 90.7% for our 4-hour target. And whilst we have had a number of challenges, actually that percentage does put us quite favourably from a national point of view, and definitely from a regional point of view. And we are starting to recover that quite quickly. We've also had a number of 12-hour trolley waits, which is something that is completely unheard of for us as an organisation. And actually, when we have reviewed those three, they were actually all avoidable, which is such a shame. So measures have been put in place to ensure that that doesn't happen again. I think we've talked for a long period of time around our challenged cancer performance, and we were actually thinking that we were starting to see that improve significantly before we got into January, where we were having to take some of those services down because of the peak. So again, we are worried it's not where it appears to be, that there is considerable focus on recovering that position. One of our most challenged specialties is particularly around breast services, because most of the referrals come in a kind of a 2-week wait, and that does impact on our 2-week wait performance. But we have done some really great work with the breast team in understanding what their challenges are, and they've been working mainly out of the independent sector at the moment in terms of that extra capacity, and that has given them some flow issues. But we are going to do a transformation piece with those. So we've got service improvement working with them now, trying to redesign their pathway now. Now we've relocated them back into the organisation as to how we start to improve that flow through. You will see within the dashboard and within the report that our waiting list position again has been challenged because we have had to then take down all non-essential surgery, but we have started that again this week, so we should start to see that position recover. And very disappointingly, again, we've seen the number of 52-week breaches exceed a level that we would not be comfortable with. So work is ongoing to recover those, and you'll see from the dashboard prior to that we were at 0. So some of these things are really quite disappointing for us, but unfortunately unavoidable in the situation that we have been in. We've done a lot of work around stranded patient numbers and working with our social care and out of hospital teams to be able to improve the discharge processes for patients, but also to protect our, as I've said before, our care and residential home providers through the COVID impact. And so we're hoping to hold on to that best practice that we have initiated during this period of time, so this can start to become business as usual, which is really, really a positive thing for us to move forward with. There's some positive metrics through maternity services, and we've already talked about Ockenden, and we will see that regularly coming back here to give the board some assurance around our women's and children's services. The last thing I really wanted to touch on was really around some of the questions that we often have around turnaround times, particularly with the pathology network. So within the report, it does set out our histopathology turnaround times, which are all reasonably positive. We have had some challenges around staffing. This is our own staff, which has caused some delay in some of those turnaround times, but they have been resolved now. And I think from a swabbing point of view, we now have in place a daily dashboard for the COVID swab, so we understand what the capacity is, what the turnaround time is, and also if there are any challenges with some of the equipment that we know has been challenging for the pathology network. And therefore we have had a much better turnaround time, which has allowed us to manage the situation during January with the increased numbers in a much more positive way. I didn't want to pick out anything out of the community, out of that out of hospital report, because as you can see, it's all quite positive. So I will just take any questions.
Thank you very much, Helen. Questions or perspectives to Helen? A lot going on, and Helen led a really interesting update on where we are with that EPR procurement work as a replacement for Lorenzo this morning. Well, thank you, Helen. Thank you to all your team for their hard work during what was a very, very difficult January into February. Moving on then, and Charles, I am aware that you need to leave by 3 o'clock, so we'll get to your items. Anne, over to you. As Glenn said, some great absence figures in the context of the situation we're in.
Of course, you don't see those in this report, so thank you, Glenn, for taking the positive. So what I did just want to highlight was the international nurse recruitment, which Anne has picked out, is really positive. So it's obviously been more difficult over the winter because we've had to understand and accommodate ever-changing rules in terms of quarantine of staff when they come into the country, but we are working through that. The challenge in relation to that is much more difficult for individuals who are coming to join us through that route now, and we are having to be particularly sensitive and careful around the pastoral support that we provide to them during that period of time. We've appointed an additional member of the practice development team specifically to support our international nurse recruits. And what I'm going to do next month is actually bring a look back across the year to see actually what we've achieved in terms of that programme of work over the year. because we are expecting more nurses to come to us in March. The Healthcare Support Worker Programme is another programme that's been supported by Health Education England, and we're on target to achieve our recruitment of 40 additional healthcare support workers. They'll be additional to a headcount at a point in time, rather than 40 over and above our budgeted staffing level, although the plan is to over-recruit. Sickness in this particular period, of course, this is retrospective validated data. So this report looks at December, and I have had the benefit of looking at January, and January continued to be a month of high absence levels, which, given where we were in terms of staff absence with COVID and self-isolation, isn't surprising. I look at the data on a daily basis, and we consider that in silver 3 times a week. So clearly, as Glenn said, the picture improves very significantly over the last 2 or 3 weeks. We've seen a great improvement in those attendance rates. And moving on, I've set out there a very detailed update in terms of leadership development. Much of that work happens at group level, and that's Dan and his team, but I've pulled out the SWFT activities into this. While the team have perhaps not been able to do quite as much as they would have done in terms of leadership development, that team have moved their focus to support staff wellbeing programmes, and that's set out here too. And there's nothing more I wanted to pick out, Chair, but I'm very happy to answer any questions.
That's great. Thank you very much, Anne. Bruce.
Thank you, Russell. Very welcome report, Anne. I especially, as you know, I welcome the leadership development stuff, because we're increasingly living in a more difficult and challenging landscape for leadership, and leadership for a lot more people than we had traditionally done. Also, of course, for the care and support for our staff. So thank you.
Thank you, Bruce. And Jeff?
Yeah, and thank you very much indeed. Very full report as ever. Particular congratulations on new applications, where the numbers are extraordinary. And well, appreciating we live in difficult times, and perhaps working in the NHS seems more attractive just at the moment. Do you get any sense that the kind of makeup of people that are applying is changing from that which is normal in terms of their history, age profile, gender profile, indeed, number one? And number two, are people applying just to come and work in the hospital, or is it a career in healthcare? Do you get any sense of that through the initial applications that are coming forward?
I think it's both, Jeff, and I think the challenge of sifting those applications is far greater than it was, particularly when we're taking applications for healthcare support worker roles or support roles generally. That actually that sort of selection in terms of making sure that we understand the motivation that people have for working with patients, and that we understand what their development needs would be following appointment. But we're having great applicants in terms of our apprentice programmes, and that's across the trust, whether it's clinical or non-clinical. And there are some really fantastic programmes available for people to apply for, so that has definitely improved. I haven't looked at whether it's had an impact on the gender profile. Possibly not, I would say.
Thanks very much.
Thank you very much, Anne. I apologise, but because we're losing Charles at 3 p.m, I need to jump the agenda. So, Kim, if you can just hang on for a second, and we'll jump down to item 7.1 on the agenda, which is regarding a safe working annual report. Charles, we've obviously read it. Particular points to put out?
Well, I think that this, demonstrates some very good work by the HR department, medical staffing, and Mr. Hashmi as the Guardian of Safe Working. You're seeing good levels of compliance with relatively few exception reports. I suppose the one issue that we suffer from is gaps in fill rate from the deanery in terms of junior doctors, but again, by investing in our clinical education fellows, they've filled the gap admirably. And you will also see that we cover a lot of the gaps through bank, 70% rather than agency. So all in all, I think it's you know, a very reassuring report.
Thank you very much, Charles. Any questions or perspectives from colleagues? Can you please pass on the board thanks to Mr. Hashmi for his hard work in this regard, Charles?
Yeah, I will.
And then I think you're due to update us on the data security and protection task toolkit.
Yeah, this is a very quick one in that there was due to be the update formally to the board at this meeting, but because reporting is going upwards has been delayed to NHS Digital, that'll now be in June. But it's just to let the board know that the 4 standards in cybersecurity that we were not compliant in, we will be compliant in, so that's some good news. And you know, the report will come formally according to the new timescale.
Okay, great. Thank you, Charles. Any questions to Charles on the data security and protection toolkit? Okay, thank you for overseeing that, Charles. And you're released from duty, so
we haven't done mortality actually, which I think again, you know, the indicators are all within control limits. It just has to be remembered that this is quite a rear view mirror measure, that we're going back to June for shimmy and November for our you know, other metrics, and we're just beginning to see an increase in deaths in November, accrued mortality, which you'd expect with COVID, and it'll be a time before we see what happened in December and January in the figures, but certainly everything as reported is as usual well in control limits.
Okay, thank you very much, Charles. Any questions on mortality from colleagues? Okay, Charles, you're duly released. Thank you for your hard work. So we'll then move back to Kim's report. Apologies to be jumping around. Kim, over to you.
Thank you, Russell. So the month 10 position is that the trust has delivered £143,000 surplus against a deficit plan of 594. We're on track to deliver a break-even position, if not a small surplus, at the end of the financial year. The only outstanding issue that we need clarity on is the treatment of the annual leave accrual, which is being dealt with at a national level. As I mentioned earlier, we don't have any impact at all in terms of either a gain or penalty in respect to the elective incentive scheme. We also actually had confirmation that there's no impact for us in respect to the non-NHS income issue either. The only key thing I wanted to note, really, I suppose, is our good progress around reducing our debtors position, which I was really pleased about. So you'll see that there's been improvement in month of about £17 million, where we've managed to reduce our debtors position. So that obviously has meant that we've had a substantial increase in our cash position. The last point is around our capital programme. I just want to draw attention to. We've done a more detailed piece of work with Sophie and the teams, etc., in terms of confirming our forecast outturn for capital, which seems to be on track to deliver, you know, just over £28 million of spend by the end of the financial year. A significant amount of the cash actually is related to the fact that those schemes are due to be finished, really, I suppose, and paid out, you know, in the next couple of months.
Okay, great. Thank you very much, Kim. Questions or perspectives to Kim? So, Kim, just going back to the prepayment. At the end of January, we had 65 million in the bank. So 25 million will reduce. So our sort of run rate is about a 40 million end of month cash balance?
Yes, but there's another 18 million which is effectively committed to pay for the capital programme.
Yeah, no, but I just think I understand that, but but in terms of at the moment, we shouldn't be thinking of ourselves of having 63 million in the bank. It's close to 40.
Yeah.
Super. Thank you, Kim. Okay, colleagues, happy to move on. So I think then we're on to the monthly safe staffing report, and over to you again, Fiona.
Thank you, Chair. Thank you. So yes, normal staffing report. The only difference this month is that it does cover 3 months worth, because we did pause the staffing report for the last couple of months. So I think it's been a challenge. I think the most challenging time from a staffing point of view, and that wouldn't be a surprise to you. And some of the figures in the report, particularly the breaches of 1 to 8 in the acute nurse staffing wards and departments, has seen a very significant rise from a normal sort of breach of 30 or 50 a month to 131 in December. And that obviously did cause a level of stress and anxiety to staff. I think I would publicly want to commend staff that they did prioritise the safety critical tasks, that and that was the message from me and the board, for them to be able to release some of the less important tasks, partly for their levels of stress and to give them permission to do the right thing for the patients, but and partly just to give them a clear steer as to what we would prioritise, or I would prioritise. I think it's commendable that the quality and safety of our patients did not show a dip in the monitoring that we do, but it did cause an issue in terms of well-being, a spike in sickness, and you saw just from the filming from last night, some real concerns about their resilience and mental health. So I just really want to stress how remarkable they have been in that very, very challenging 2 months, particularly of December and January. From a staffing point of view, it really did change the profile. I think from a nurse staffing position, we've already said we're in a good position. Vacancy fill rate is good, and so is bank fill rate. In terms of maternity, there has been a spike in sickness and maternity leave, but they have plans in place and are managing that as a division. AHPs, we've talked in the report about there being some hotspots around certain disciplines, and to bring the attention to the board of particularly theatre staffing. Charles alluded to that earlier on, that there are gaps in the operating department, practitioner establishment, and again the division has been tasked to try and support the health and well-being of that team, and therefore improve recruitment and retention. And then going to the out of hospital teams, the areas that I would flag of concern, but there's mitigation in and actions being taken, is the sick children's team, and the North team have got some challenges, particularly around restricted duties and maternity leave. But again, each of those individual members of staff are having their risk assessment related to COVID, having those wellbeing conversations, and the managers are closely monitoring that. So I suppose in conclusion, it has been the most challenging that I've seen it in terms of staffing. We've had calls for all CNSs and corporate nursing, and we've all done shifts, and that's pulled us all in to help. I think we've got through it, and patients haven't seen any poor outcome as a result. but the focus on well-being and staff resilience and recovery, I would support what Glenn was talking about earlier on.
Thank you very much, Fiona. And I think no one can overestimate the impact on our staff in terms of physical and emotional exhaustion at the moment. And as you say, the Channel 4 piece last night really brought that home. Members of the public may not be aware, but Sue Whelan-Tracy has agreed to be a non-executive director wellbeing guardian, which I think will be important going forward. Any questions or perspectives to Fiona? Fiona, thank you for your leadership during what has been a very, very tough couple of months. It isn't easy for anyone. So the Audit Committee report for the 10th of February. Rosemary, anything you particularly like to pull out?
Yes, just a couple of points I wanted to bring out. As we're approaching the financial year end, there will be a few changes regarding external audit this year, largely COVID driven. The key point is that the quality accounts, the quality report, like last year, there'll be no requirement for an external audit of that. And it also looks like going forward, it's going to become an optional as to whether they are audited or not. The auditors have also, their date for reporting has also been delayed. So in the past, the accounts had been signed off in sort of late May. The deadline for sign off is now early June. And as a result of that, I think it's been decided that the board meetings are going to be moved so that the board meeting will take place at the beginning of June in timing with normal board meetings. Other points which we talked through at the Audit Committee, we had a presentation from the IT team who have been looking at improving controls around controls over both IT access and IT assets of staff, particularly of staff leavers. And we've been very assured that there's been significant progress made by the IT department to improve controls, particularly over access to the network when a staff member leaves the organisation. There's still a potential weak link in that obviously line managers still need to be telling ICT when a member leaves, so there's some comms training needed around that. The other area I just wanted to bring out was the internal auditors carried out an audit of the pharmacy wholesale dealer's license. Now last January 20, the MHRA came in and carried out an inspection of the pharmacy, which revealed shortcomings in their controls. This is where we sell, as where the hospital, the trust sells pharmaceutical products to other organisations, so that's a requirement for us to have this wholesale licence. So it's really important that these controls and procedures are improved. The MHRA are likely to come back fairly soon and repeat an inspection. So the internal audit was carried out just to make sure that the pharmacy team had got all their ducks in a row in terms of making the changes as planned. And actually, having carried out that review, they did find a number of shortcomings, and so now there's been far more focus on improving their action plans, getting evidence together, so that when the MHRA does come and visit us, that all the data will be there for them to be able to see and sign off. So there's been a lot of focus driven by the head of pharmacy in terms of improving compliance there. So whilst it's a report was only gave sort of moderate assurance, I think the Audit Committee is satisfied that as a result of that report, action is being taken so that when the MHRA next comes in, it should be.
Thanks, Rosemary. I mean, Glenn, you and I did talk about the HMRA thing, and I'm surprised that we got ourselves into that position. Any comments from you?
Yeah, I picked it up with the team following our conversation. Obviously, as Rosemary sets out there is an action plan to address the issues. The impact of this would be, though, on the services that we sell from a trust perspective. So the aseptic service would be a good example of that we've been setting ourselves up to do. It doesn't relate to the pharmacy arrangements that the company operate out of the dispensing pharmacy on site at George Eliot, but nonetheless it's important to address, and the team are tackling those issues.
Yeah, I think generally, we're an outstanding trust. We shouldn't have gaps in control like that. We're an outstanding trust, and we need to, act like Premiership League winners. And I'm a Manchester United fan, not like a Manchester United team on occasion, just getting over the line. We're better than that. We shouldn't allow this type of stuff to happen. We need to move on, Rosemary. Any questions or perspectives to Rosemary? Sorry, Rosemary, did you just want to make another point?
No, what was important was that the request for that piece of work did actually come from the head of pharmacy. So it was, internally the organisation did identify that there was a problem. Yeah. And internally they're going to help.
Moving on then, and we need to pick up the pace a little bit, guys. Apologies. The Clinical Governance Committee report for the 10th of February.
Thank you, Russell. I just want to make two comments. One under point 1 general. The committee will continue in the informal joint mode with our CCG colleagues. And the other point I'd like to make is that I welcome the treatment of COVID infections in the trust as serious incidents, because I think that's a very appropriate way of learning from what's happened. Happy to take questions.
Thank you, Bruce. Any questions or perspectives to Bruce? And I know, Bruce, between you and Simon, working with Helen, lots of focus on cancer performance at the moment, so thank you. Therefore, we'll move on to Simon. And Simon, what would you care to pull out of the 2nd of Feb and the 2nd of March meetings?
Okay, thank you, Russell. The 2nd of Feb is just reflecting the verbal report I gave at the last meeting, so I don't intend to focus on that, other than to acknowledge the currency now being given to respite, which I think is excellent. Yesterday's meeting, we returned to more of a full fat agenda. We had a COVID update followed by a discussion around the recovery plan. And this was an encouraging discussion. We recognise the system focus and the need to help each other, but also the blunt focus, I think, on P2 activity that doesn't reflect how we use other resources totally. But of some concern, I think, is lack of clarity about how money follows the activity around P2, I think, and there's some need for more clarity in that area as far as I can see or I received in. We discussed changes to the performance dashboard, and I think there's a challenge around the dashboard of it's continuing to get bigger as we reflect on it, and somewhere it's becoming, I think, an unwieldy tool. And we also had a very good discussion around productivity measures, and Kim and her team, with the help of operations, came up with some very practical measures of how we measure productivity and how it can be used as a management tool. And in due course, I hope that we'll all be able to reflect on good work done and see how we can use those to help drive the trust in a better way.
Great, thank you very much, Simon. Any questions or perspectives to Simon? Good to see you back on the full fat agenda, so to speak. And then the Council of Governors report for the 11th of February. This was an unusual Council of Governors because it was just run by all of the non-execs, and the execs we allowed them to send apologies in the context of everything going on in COVID. So I'll take the report as read. Any questions on the Council of Governors report from the 11th of Feb? Okie dokie, so we move on, and we were talking about stars in the organisation earlier and people who are absolutely great exemplars and ambassadors for us, and Sue, at that point, I'm delighted to welcome you for the quarterly report. Sue is our FTSE guardian, so, or FTSE guardian, yeah. So over to you, Sue.
Thank you, Chair. So this is Q3's report. It's quite full, quite granular, quite a lot of information in there. And I think of note to say, going forward, because we've got data like Model Hospital now, and there's a lot more data from other organisations, our reports will perhaps look different going forward. And we can do a bit more of data analysis and a bit more around assurance for the board rather than it being quite narrative. So hopefully the board are happy with that rather than reading my school report. Of note, this quarter, we've had 29 cases. So if we look and compare that backwards, in 2018, we had 18 cases in the same quarter, and in 2019, 14. So cases are going up. Not surprisingly, with everything that's happening, and as colleagues have said, COVID has had significant impact on how staff are feeling and how they're acting and behaving with each other as well. I think that's reflective in the graph that shows bullying and harassment and attitudes, behaviours, leadership as our key indicators, and also the mental health element as well coming in. So you can see that staff are tired, staff are rightly getting upset and anxious. So most of the casework I'm dealing with, including in this current quarter, is around more pastoral care really, and more advice and support. The bullying and harassment seems quite high in this quarter, and it's probably important to say that that revolves around one specific case. So 6 of those individuals pertain to the one case, so it perhaps isn't as high as it looks on the graph. The length of case, you'll note there's a couple that have gone over 6 months. Again, those 3 cases relate to the same area, and it's just been a long process getting through grievances and appeals and HR activity, and also supporting those individuals going on. So that's where those outliers are. Really pleased to see, as we start measuring the data on that, that actually the majority of ours are closed off within 4 weeks. So that's really good, and thank you to everyone that helps with that. I think the last page around lessons learnt, we had the discussion at George Eliot Trust Board yesterday. These aren't necessarily specifics for SWFT. Some of the things like the one around civility, the narrative there comes from the civility campaign, and it's just a reflection, and maybe from speaking to staff, not all staff do still feel safe to raise concerns. Some staff, if we think about our BAME community, our staff that are from an LGBT background, because I see those individuals and because I'm with them at networks, they do often reflect a different story to maybe how I feel about speaking up in the organisation. Their learnt, their shared experience, their lived experience is different, and that's where the fear factor comes in, and where that hierarchical nature of our NHS comes in. Staff aren't always happy to speak up to a senior member, so that's where that comes from. And I think another really important thing is our ambassadors. Our ambassadors over the last couple of months have been absolutely fantastic. They've really been helping to spread that wellbeing message, spread the love and support each other. And I think going forward, we really need to look again at how we support them, how we grow that network of people. It's great to hear that Sue William-Tracy's on board as our ambassador for wellbeing. And I think together we can really support that network and make sure that every area has an ambassador. A really good thing about speaking up where you have a really meaty case is often we then get ambassadors off the back of that, because staff see the effect that they can have. So that's been a really positive as well. So happy to take questions.
Thank you very much, Sue. Glenn.
Not a question about the report, but just to congratulate Sue on taking on the role of regional chair for the Midlands of all of the Freedom to Speak Up Guardians. So the guardian of guardians, I think.
Yes, I'm more and more like an Avenger every day.
Well done for that. It's great for the trust as well.
Yeah, no, well done. And Sue?
Yeah, hi Sue. You definitely are. You definitely are an Avenger, and I'm not sure how you get everywhere you get, but thank you for the report. Really comprehensive. I just wanted to say I'm really looking forward to looking in the next few months at how we work together more. And to say that I, just as a taster for colleagues, I think one of the first discussions we ever had, I was saying, what aren't we asking you? What should we as a board be more concerned about? And I noticed that lots of those things have really come through in the last year, and it's really, really just to say that I'm delighted to hear the points that you just pulled out about the wellbeing guardians, etc., because I think that I've met a lot of them, and then I think they've got a huge amount to offer. So thank you.
Thank you, Sue. And any other comments? I'd just like to make a point on civility saves lives, because going back to your point on bullying, so we are very focused on the civility campaign. It's obviously been more challenging with COVID, but now as we come out of COVID, we really need to ensure the profile of civility saves lives is increased, and kindness, being genuine and authentic with colleagues, but recognising the stresses and strains that everyone is under is incredibly important. So thank you for being at the forefront of all of that. Take care, Sue. Thank you for your time. Look forward to seeing you again soon. And then we've got the COVID-19 update. Helen?
Sorry about that. Just couldn't quite get myself off mute. Thank you. Thank you, Russell. I don't tend to go through the contents of the paper because this is the irregular report that you have, and I think that the majority of things that we've talked about today is contained within the paper. But if I just draw your attention to some of the charts that are in the report, which I think are actually quite enlightening, really. So if we look at chart A, that really compares our second wave to our first wave, and in the first wave, when we thought it just couldn't get any worse, lo and behold, it did. But I do think that we're not completely out of the woods yet. So we do need to, and the members of the public and us all, we need to be cautious. We need to take our time, and we need to do the right things. Otherwise, the minute things are all lifted, we could potentially be straight back into another surge. And I think we've heard many of the discussions here around the resilience of the staff, and I think the Channel 4 programme really brought home to us, didn't it, that emotional impact that it has on our staff. And humbling as it was, I would worry for the organisation if we surged again quite quickly. And so I think it's my caution is what I'm saying, because we have got a lot of work to do. So if we then go through chart B and C on the following page, just set out some of the rates per 100,000 population, and again we are starting to see that fall, so that is very positive. But every now and again we see a little increase in the numbers, and again we just need to be cautious. And then finally the chart on C, which is our usually our 50-bed challenge chart. And so just to demonstrate that whilst the performance is challenging, actually we are operating within our bed base, but actually the challenge is on the flow, given the impact that COVID has on us. And I think the only thing I then wanted to really say is that we are starting to prepare for this time next year. And we have got a lot of work to do, because what are our assumptions? What does that start to look like? What do we think the impact of the vaccine will have? And I am sure there will be some national guidance that comes out for us, but we can't always wait for that. We need to be planning now. And you know me, I like a plan, and I like to start working on things well in advance. So we are starting to do that piece of work, just like we would normally do. Gather the data, get the teams together, and then start talking about what went well and what didn't go well. But also around those assumptions. So I've got Duncan, Vernon, and Paul Hughes-Webb doing some modelling for us around what those scenarios will be. So I'll start to bring that back to the board, and it may be better that we start to have the detail of that maybe in a workshop in terms of some of those assumptions, so that we can thrash those out in a bit more detail. But you know, positive in the fact that we believe we're hopefully we've seen the worst and we're starting to move forward, but air of caution, I would urge.
No, absolutely. Thank you, Helen. And just for members of the public, if you are offered the chance to go for vaccination, please do take up the opportunity. It's your best way of helping the NHS, and even once you've had your vaccination, please continue to wear a mask, socially distance, and stay at home if you can until we are in a stronger place. Any questions to Helen? Okie dokie, thank you, Helen. Always like contingency planning. 7 P's, proper preparation and planning prevents poor performance. So we'll move on then to the committee minutes of the open meetings. First of all, Rosemary, anything you want to add to the minutes of the 8th of December, Rosemary?
Nothing to add. Nothing to add.
Thank you. It's 9th of December, I apologise. Thank you, Rosemary. Any questions to Rosemary? The Clinical Governance Committee of the 13th of January. Bruce, anything you want to add?
Nothing to add, thanks, Russell.
Any questions? Thank you, Bruce. Any questions from colleagues? And then the NED F&P of the 1st of December. Simon, anything you want to add to these minutes?
Nothing to add, Chair. Thank you.
Any questions from colleagues? Any other business from board members? Please raise a digital hand if you have. So we'll then move on to questions from governors and members of the public. Sarah, do you want to lead on the questions that we've had from members of the public, please?
Yeah, thank you. So we've got 2 questions. First from Roger Lloyd, Public Governor. The first one is it intended that Building 1, the new building at Stratford Hospital, should become a diagnostic centre for SWFT with a new CT scanner installed? Building work is currently being undertaken on site, hence this inquiry. And Sophie's going to answer this question.
Thank you. Sophie.
Thank you. So the work going on at the moment at Stratford is to move diagnostics from the old hospital into the new hospital. But also as part of that, that will give us some additional capacity. And it's a case that was signed off by board about 12 months ago. It's due to finish about mid-April. And so that will be a great move forward in terms of having that access to diagnostics. In terms of the CT scanner, we were really fortunate that as part of the request from Helen around COVID recovery and coping during the pandemic, we got access to a mobile CT scanner through the regional team. They have confirmed that we can keep that. So we're now looking at maximising that resource to support us with the recovery that we now need to do. So in terms of it becoming a diagnostic centre, it absolutely is one for SWFT. It has a potential to be bigger, and we're taking part in the conversations across Coventry and Warwickshire now about the future direction for diagnostics. And Helen is sitting on the diagnostics board for us to sort of navigate some of those conversations. And we will, of course, bring that back through board and governors as and when is appropriate.
Thank you very much, Sophie. And then the second question from Roger, Sarah.
Thank you. So this is regarding the pathology network. Can the governors be assured that the executives can and will find a way to secure that level of service that the trust needs in order to deliver an outstanding service to the trust's patients and the people of South Warwickshire? Collectively, we have been raising questions about the network for a number of years, and with the new structures and architecture of the NHS coming within the next 2 years, this seems to us that there is an opportunity which should not be wasted. Should we dissolve the partnership and find another partner more capable of delivering the required level of SLA?
Thank you, Roger, for your question. Glenn?
Yeah, it's slightly more complicated than that, I'm afraid. I mean, I think one of the things that COVID has taught the NHS is that we haven't got a sufficiently resilient pathology service across the NHS. And a few years ago, there were attempts to do that through the creation of networks. And indeed, we were at that point encouraged is probably too light a word, to join the Coventry and Warwickshire network. I can only see those arrangements being strengthened in the future, with networks being the only way that we can operate. So I don't think there's an option for us to choose to join another network. That said, the way our network works does need to be improved, as does the performance that you refer to, Roger. And I mentioned this at the start of the meeting that I had a conversation this week with Neil Anderson, the director of the network, and we will continue to push that. Within pathology, though, there's some real assets, and one of the key assets actually is the histopathology service that we've set up here, based at South Warwickshire, which is technically part of the network, but actually has the ability to be expanded because we've got a really good recruitment model. So that's one of the other things I'm using to negotiate the best arrangement for the trust. But we need to keep on top of this, as you imply.
Thank you very much, Glenn. And then, Sarah, I think we had a question from Jane Knight.
Yeah, thank you. So Jane would like to ask what steps the Trust is taking to make sure that members of the Black and minority communities will have an excellent treatment and care as white communities in all aspects of the medical care given by the Trust's hospitals. I think Fiona's going to answer this one.
Fiona?
Yeah, thank you, Sarah. So when I read this question, there was a number of things I wanted to say, really. I suppose, fundamentally, registered nurses, doctors, therapists have a code of ethics and code of conduct that, we shouldn't be prejudiced, we shouldn't be judgmental, and we absolutely need to treat people equally, no matter what their background and choices in healthcare. I think I have no concerns that our patients from a BAME community are treated any differently, and that doesn't come through any of our feedback or patient engagement pieces. I suppose the ongoing pieces of work around that, and Jane specifically said about hospitals, but it is wider than that, isn't it? So we've put particularly into our trust objectives around health inequalities and the wider determinants of health and health populations, because we know outcomes for BAME patients and people, health outcomes for BAME people are often different from their white populations, and so it is more about the wider determinants of health being housing, education, information that is tailored to those populations. And as Glenn was alluding to earlier, the vaccination programme is a prime example of that. It has been open to all, but hasn't always been accessed by all. And I'd say that shows that we still need to do more around information. But Jane, I think just to allay your concerns, if you had them, around are they treated differently, I can assure you that there is no evidence that anybody is treated any differently, and we do specific pieces of work. For instance, during COVID, we tailored our education and information for BAME mothers and fathers around encouraging them to access healthcare. The other piece of work that Sophie and I have been doing as an objective from this year has been looking at that in public engagement strategy, and our approach going forward will be to proactively go out to some of these disadvantaged groups when we're doing public engagement, patient education and information as a system to make sure that we are targeting those groups and accessing those groups.
Thank you, Fiona. I know there was a programme last night with David Harewood, the TV actor, talking about why is COVID-19 killing so many Black people or people of colour. And I think, Jane, that there will be a piece of work which needs to come out of the COVID-19 experience. And you just mentioned in your in the chat box about maternity services as well. So I think this will be an ongoing debate, but hopefully Fiona's answers give you some level of assurance. I'm conscious of time running on, and we've got the confidential board. But Ruth, we were aware of Dame Fiona Caldecott's sad death last month, and that she lived in Warwick. But Jane, did you have? Sorry, Ruth, did you have a question to Glenn?
Well, I just noticed that Glenn mentioned in his report about inequalities when he was talking about staff. You just slipped in, and I just thought, "Ooh, what's that?"
Oh, Glenn, what was that?
Yeah, so I'm referring to a couple of things there. I mean, firstly, the work that's being done to address inequalities is something that's very much top of our list as we move forward with an integrated care system, but specifically related to vaccination. Firstly, encouraging our staff to be the ambassadors to address some of the stories that are out there, the myths about COVID. But there are some groups of staff, when you analyse the take of a vaccine, that we just need to ensure we address any concerns they may have. An example of which actually would be young female staff, because there was a concern about fertility. The internet has brought many wonderful things, but it's also brought social media, where people are allowed to put utter rubbish on social media and people think it's true. And the issue around fertility was simply that there hadn't been enough evidence to demonstrate that the vaccine was safe, but that because there hadn't been enough pregnant women or women who were seeking to get pregnant who had been vaccinated, and therefore they could assess the impact. That turned into people feeling there was a risk associated with vaccination for those staff. And it's those kind of things that get misinterpreted on Twitter and other places, which then lead to individuals not taking things that would keep them, their families and our patients safe. So we're just trying to make sure that we answer those questions so we don't bring any more inequalities into healthcare. Hopefully that's a question.
The screens in different areas for putting out the correct information, you know, in casualty, in the canteen, around the place where we've got screens. Are we actually putting the message out?
Yeah. So we are. There's a whole load of material that's gone alongside the video that I put out to staff, where they can access it and address these questions. Obviously, comms are slightly different at the moment compared to what we would normally have, where you normally have places where lots of people gather, where you could put comms messages out. People are not gathering together in those places, so we're using all sorts of mechanisms, including very regular COVID briefings for all of our staff, using our intranet and other means.
Okay, thank you.
Thank you, Glenn. Thank you, Ruth. And thank you for members of the public joining us today. The next board meeting will be on the 7th of April. In the meantime, take care. Please have your vaccination if you're offered it. Continue to wear your mask, continue to wash your hands, continue to socially distance, and if possible, stay home. Thank you, everyone. Take care. We'll now sign off of this meeting.